Today we have Ronda Erlewine Belgarde, and you want to know what, Rhonda? I feel so bad because I didn't even ask you how to pronounce that ahead of time, and I usually am better at that. Um, Rhonda is a licensed clinical social worker that has been in the position as the Montana Veteran Health Administration Intimate Partner Violence Coordinator since January of 2025. The Montana VHA IPVAP coordinator's role is to provide agency guidance, program development, and direct services within Veteran Health Administration to veterans, their families, and VHA employees that either may be receiving or providing intimate partner violence. Previously, she was employed as a senior PAC social worker for the Montana Veteran Health Administration for the past 5 years. Services include providing assessment services and community connections to veterans and caregivers that have medical issues and complex social or environmental safety needs with the objective to address personal health, safety, and well-being. She has over 30 years of human services social work experience in the areas of community, medical, home-based social work, Montana State Adult and Child Protective Services, residential therapy services, adult and children residential treatment centers, and working with clients and children that have been impacted by trauma stemming from intimate partner violence and interpersonal violence. She holds a Bachelor of Social Sciences with an emphasis on adult corrections from Montana State University and a Master's of Social Work from the University of Montana. She's a licensed clinical social worker and has training in clinical hypnotherapy and certified trainer for the Veteran Health Administration Strength at Home program, as well as the Pending Rise clinical provider. So, Miss Rhonda, I'm going to go ahead and hand it over to you, and we'll go ahead and get started. And then if anyone needs anything from me, just let me know.
Okay, thank you so much, Tawny. Can everybody hear me okay? Can you? Okay, very good. So yes, my name is Ronda Erlewine Belgarde. You did very well. With the Montana VHA, I've actually been in the VHA for about 5 years. So the population I'm going to talk about is literally the veteran population, and we will get into that a little bit more because it's within the Veterans Health Administration. So it's people that are enrolled in veteran healthcare or to know what could be available as you may be encountering families that have a veteran. And my hope and goal out of this is that even if you just inquired, if they're a veteran or not, you can send them our way. We can kind of talk about what it takes for enrollment. And I will have some resources that are links where you could just pull it up and be able to talk with the family about it. So with our program, what we focus on is intimate partner violence, slightly different from domestic violence, but of course also is very much an overlay with what we do. So domestic violence is anything within the domestic sphere at home that could be child abuse, elder abuse, and other types of interpersonal violence. And we definitely do have some services within our program, within the administration that can help in those areas. My focus is more on that very select intimate partner violence. So the physical, sexual, psychological harm and stalking behavior by a current or former partner that can be a one-time episode or it can be an ongoing type of situation. People do not have to be cohabitating together. They do not even have to be in an intimate relationship. What we look at is if it's a situation even that I've had people come to me that have been free from the relationship for over 3 years or more, and then all of a sudden the partner, ex-partner will contact them through social media. And I had one saying that he was going to come up and kill her. And so, of course, that brings up a lot of trauma, a lot of things, and bam, we can be involved on that level for sure. So the types of IPV that we look at is the physical, sexual, emotional, as well as the overlay on stalking. So we do this within our veterans healthcare clinic, and my role is to work with primary care to understand, that people are going to come in. They're probably not going to come in and say, I'm being abused, I'm afraid for my life. what they're going to do is come in with symptoms. So what we look for and what I train folks for is to be able to pull up, you know, this type of information that would lead towards IPV. So as far as an overview, this was a research program in 2019 that kind of talked about comparison of IPV prevalence across populations. So we have that. And the most notable thing is that 40% of the women veterans reported experiencing IPV in their lifetime. And also 27% of the men reported experiencing IPV through the lifetime. So I really focus on this as a human issue. This is not a sex or gender issue. Some of the veteran-centric factors that kind of pull veterans apart from the general population is that we have our population sometimes with post-traumatic stress. They have military life stress, separation and isolation due to long deployments, mental health concerns. And a lot of times in the military, those mental health concerns are not addressed. They're not even to be talked about. It's about the mission. And it's about, you know, the military culture is very, very different. And so they're coming back and forth and they're carrying this load with them. Alcohol and drug use, uh, loss of trust and moral distress. You know, we have people that literally are going across seas and they're ordered to kill. And, you know, in the general population, if we took a life, that could traumatize somebody for life. And yet this is something that this person is expected to do and yet come back, you know, to our world that is much different. Um, Traumatic brain injury. Many people, you know, they do have traumatic brain injuries from falls, from blast, a lot of blast, IUDs, and also the increased anger. I mean, the frustration tolerance of these two very different worlds that they're involved in results in decreased frustration tolerance. That, you know, if you've ever been over into a military type of facility, you have people walk on one side or they walk on the other. They look straight ahead, their body, everything is very straight. And I come ambling through, you know, in the middle with all my bags and everything, very different. You could almost see a little bit of frustration at times because it wasn't in order. You know, I was all over the place. And I've had people even talk to me about they can't even go to Walmart because one was a drill sergeant and he wanted to straighten up the lines. And then people were wearing pajamas. You know, I mean, there's just so many different types of culture differences. And the issues can lead up to increased risk of divorce and broken families, loss of support, homelessness, joblessness, poverty, increased healthcare needs, justice involvement, as well as suicide ideation, and can be homicidal as well. So, in our general population, as far as people who have received IPV, they estimate that maybe 1 in 3 women and 1 in 4 men. But when we get to the veteran population, because it is such a different type of culture, and if people have trauma from that, it can be twice as high. So it could be 2 in 3 women and 2 in 4 men that have received IPV. So the overview of our program, our vision is that veterans, their families, caregivers who receive care from VA, as well as employees, would not experience or use abuse and would be free of negative consequences resulting of that violence. The mission is to implement a comprehensive, person-centered, recovery-oriented assistance program for veterans, families, caregivers, and VHA employees who either use or experience intimate partner violence. And so what I have here is the timeline of when this started, which was May of 2012 with a task force. And by April 2018, the program was fully funded. And in every state, it is mandated that they have an IPV coordinator, and some of them even have 2 that are in place at this time. So how we might differ from the community is you will usually have like communities that will strictly provide victim services. They call victim, we say experience, people who experience IPV. And then you have another community altogether that will address people that provide IPV, and there's programs that way in the community. So with our agency, what we have is we have services that address both. So for veterans that experience or use IPV, we go down the pillars of that it's veteran centric, person first. It is a trauma informed intervention for both populations, and it's recovery oriented. So we work very hard on instilling hope that things can change. This is not a label, and not something shameful. You are here because of maybe some of the trauma and things that are influencing and coloring your world on how to react. You go from 0 to 60. We're talking about the brain can change again and is constantly changing through your life. And so we have some tools and techniques to help that person with that as well as support. So part of my program is to raise awareness. I do attend events. I will be up in Great Falls in September and other events where I have a table that has many different programs about VA on there because I do believe they intersect and help with the reduction of IPV by having those services in place. Um, just building partnerships and contacts with all of you, just being able to know that I am a person you can contact if there is someone in a family with your client that might be a veteran, just even asking those questions before going further. So it's not just giving them a number and they have to cold call it. We work with those that experience IPV. So there is a program we actually have in place. It's individual and it is through VBC, or if they're close enough to the provider, it could be in person. And it's called RISE. And I will go through that a little bit later. And then there's also for those that provide or use IPV, we have a program called Strength at Home that is a group program. We also work with VA staff, and this is where I network with all of you to make sure that people are connected in our employment to IPV services, that they are safe, that their workplace is safe, their home. So I will work with employees on that, and they do not need to be a veteran for that. And I also will serve partners too, or family members, and that's where it's so important to kind of know what's out there because it's a way of kind of helping them navigate the system so that they can be educated of what's out there in the event they need it. IPV in healthcare, why would we care about having IPV intervention in healthcare? And in 2005, there was a study completed where the result was that patients believe healthcare providers should screen for domestic violence and IPV. The benefit is the providers can discuss abuse and violence in context of healthcare and help patients understand the connection between abuse, that fight or flight, and how it is affecting their physical, mental health, as well as their well-being, and with the lab test and everything else that is going on. Whoops, I apologize. And here is on the bottom, it says healthcare is supported by, we have task force recommendations, health resources and service administration, centers for disease control and prevention, and the United States Preventative Services Task Force. We have a Senate report, and we also have VHA directives regarding women's health and military sexual trauma, that's MST. So we have programs for both of those, for women specific as well as military sexual trauma. And this says pending VHA directive 1198, but it is actually in place. So it is active at this time, and that is what we operate under in our program. So some of the medical issues that could kick up that people come in for, because they come in for talking about symptoms. And this is what I kind of work with the medical community on to make sure that we kind of pay attention to it. That, there can definitely be physical symptoms of IPV that could correlate with that. And here's all the diagnoses that can be out there. A lot of times I hear of headaches, chronic illnesses, TBI, and we do have a TBI screen, but it's important to also we do have a health safety screen that we do. It is annually, every year, as well as available upon need. And so working with the community, many different programs to say if the hairs kind of stand up on your head, like it may with someone that might be suicidal, go through the screen, and you can interweave that in your conversation so that you can, get the best data. Mental and emotional things that people could come in for that could be connected to IPV could be misuse of medications, PTSD, anxiety, substance use, and stress, as well as even homicidal thinking. But a lot of what I have heard is the anxiety. Women coming in and saying, I don't know, I'm just so jumpy. I just go from 0 to 60. It's affecting my marriage. And it's affecting what's going on here. I just don't know what's wrong with me. Or give me a sleep medication to help me sleep. And if we don't do that relationship health safety screen, you might be medicating somebody who's laying next to someone who tries to strangle them or choke them. So we have to be very careful about the type of medical intervention that we do provide, and that if IPV is present, that we take that in account. The social issues, I have a lot of trust issues, with the women and men that come in, a lot of shame, but they're afraid. They're afraid of what's going to happen next. Many are isolated. They do not have that social network because they've been isolated due to the relationship. Work disruption, that can be the partner trying to say, you don't need to work, you need to be home. And disrupting the work environment, or just the person handling the stress of everything else and it is affecting their work. Poverty, a lot of times people are afraid to leave a relationship because they're not financially independent. Or they're worried that if they leave, that they are going to put their partner in peril. Housing disruption, that can also be the same thing too. I mean, I've worked with women in particular that are living in their cars because that's what it took to get out of the relationship. And definitely intimacy issues can be paramount. So IPV and substance use, definitely a strong correlation with that. And in fact, Strength at Home has a pilot program going on right now to research how well motivational interviewing up front with somebody that identifies using substances helps in reduction of violence. So it is people need to not be in Strength at Home yet. It's prior to them entering Strength at Home, and then they follow them through, and it can be up to 9 months with contact surveys, even some financial incentives for completing surveys. And that's what they're looking at because their research shows, which makes sense, that there is such a strong correlation between the increase of violence and frequency, as well as alcohol in particular. So this talks about, 50% of the men in substance abuse programs reported using violence in their relationship, and 50% of the men's batterer intervention programs also report using violence, and that a person can be 8 times more likely to use violence. So really important to kind of, when we can, take both avenues at the same time. So they're looking at the correlation of Strength at Home program along with some substance abuse intervention. So we're getting into Strength at Home. Strength at Home is a program that was developed for veterans in military in mind. It is an evidence-based research program. It is constantly going through research and data review all the time, fidelity review. It is specifically for veteran and service members who use violence and aggression in intimate relationships. And this can be right up at the earliest point of psychological, when someone says, I can't even address conflict because if I do, I'm afraid of what I'll do. I'm afraid that I'm just going to go. I'm doing everything I can, getting up in the morning to try to keep my head calm. It is a 12-week program, and it does have follow-up. So we do need permission from the veterans, but if we get that, we will reach out to the partner. We'll also do some assessments. We'll make sure that they're aware of what's available in the community, and then we do a post follow-up on specifically looking at, was there any type of psychological coercion, stalking, physical type of aggression, or threats to harm or kill. Motivational interviewing is really the main component that is used all the way through on the group process, and it is a group process, and it's not a mixed sex, it's a same sex type of group. And the results from randomized controlled trials were 135 male veterans and 111 female partners reported that they had greater reductions in physical and psychological IPV use and reduced controlling behaviors involving isolation and monitoring their partners. So that was for people that use IPV or afraid they could. They can be court ordered, but they can also self-refer at any point, and the earlier the better is what we're looking for. So this program was developed within VA and with our military in mind, and this is for people that are on the receiving end of interpersonal violence, intimate partner violence, and it has different modules. So it has up to 8 modules, and you can see them there. It's one-on-one. It's not a group format because we really work on self-efficacy and empowerment. And so it's about trying to have that person even selecting the choice of what they want to focus on first. So just because we have safety plan first, that could be the last thing they address, or maybe not at all. I mean, they have total choice in the modules that they want to address, and they have a trained RISE provider that will go through them, each module, and review, and sometimes we'll go through the same module a few different times. They decide how they want this intervention to occur. And it's all about helping them with making decisions and safety decisions for themselves, their families, their children. They can choose to remain in a relationship or leave. So we're not forcing it to be one way or another. We're just working on that empowerment and that safety, and recognizing that they know what's safe and they know when they need to make that decision, but we're there to help them with that. And the resources that Tawny probably put on the chat already are here. And these are some of the resources that we look at within VA that we give out. And the bottom one, Strength at Home website, they are starting to work with the community. So if there are community individuals interested in learning about this program and implementing it in the community, they will work with you on that. So this is their direct website. You could pull it up. You could see what this program is about. You could read the research articles if you wish. And then here are some other resources. And because we're talking about veterans and VA, VHA, again, they are people that typically are enrolled in Veteran Health Administration. So what I did is I put the hyperlink on that talks about eligibility just briefly, as well as the one that talks about how to apply. They can do this online through this second hyperlink. Maybe I should do this so you can see my cursor. I apologize. And then the bottom one is just the PDF itself. And the PDF is an application that you can have them download, print. They could fill it out and it goes to Fort Harrison VA. It goes to enrollment. They do need to have a DD 214, and what that is the paperwork that said they were honorably discharged. And anytime somebody leaves the military, they are ordered to file that with the court in the location that they go to from the military that they're going to reside in. So that is one way to look for a DD 214 if someone hasn't done it. And another way is, let's see, right here on the hyperlink, I have the Office of the Veteran Service Officers. And they are from the benefits part of VA. So they're not clinical or medical, they're benefits. But we do have a person here in Butte. You will have a person in each county. And this link that I put on should actually just pull up a list based on town and who the contact person is, to give that person the number and they can call, and that individual can help them with being able to get a replacement DD 214 because it is somewhere on file. And then I think I did also another one down here that just talks a little bit more about what the veteran service officer does. Because a lot of times when people come into VA, sometimes they're coming in at older and almost at a point of retirement. And there might be things that are going on with their health that could be tying them back to the time they were in their military. Even the diabetes, the PTSD, there could be toxic exposure stuff. There could be a TBI where they had a TBI and someone said, you're okay. They went back out on it, but they always kind of struggled with their issues and their thought process. So some of those things can be connected to a service connection. And if that is a case, that can also lead to enrollment in VA that does not become income based. So it is a good thing to know the veteran service officer out there if somebody is just totally foreign to VA healthcare and they're worried that their income might be too high. I would always recommend that people fill out the enrollment and see what happens. And if it's showing that their income's a little high, know that and come back later when it is lower or when it has changed, because a lot of times it will. So here is also some other resources that VA has. I put just a general website here as far as mental health because it had a lot of different links on it that deal with women's health, the caregiver program, as well as the PACT Act for like emergency mental health. If somebody is in crisis, feeling suicidal, things of that nature, there is an ability to get temporary mental health care from VA, which is nice to have. The caregiver program actually has a caregiver liaison that's available to meet with the caregivers as they need. They will develop support groups and they're kind of the go-to person on even retreats and things like that. Caregiving is a very special piece and there is a lot of stress that can be associated with that. So whether it is that the person you're working with is a caregiver, maybe to their partner who's a veteran, or maybe it's another family member. It could be their parent or, grandparent or someone of that nature that's in the family that they're in the position of doing care for that may be a veteran. Just kind of want you to kind of think about that sometimes enrollment doesn't have to be about your patient. It can also be the partner they're with, but it can also be other family members that they're doing services and providing care for, that if they had some relief in that area, that might help their situation as well. So it's about kind of being creative with the resources that are there. One part of the program is with veterans. There is the option or opportunity of home health aides and respite care if we have people that meet the criteria. So they either have to have the physical need for dressing, standing, walking, showers, eating. You know, if they need help with that because they might choke or they have dementia, and that person is stepping in, whether it's in the veteran is in their home or they're going to the veteran's home, that might be something that is a source of relief. So it never hurts for them to ask and see what could be out there to help relieve some of the stress. I do know the homemaker program that can go from anywhere from $35 to $50 an hour. And with VA, it'll be a $15 copay for the assessment. And then 6 months later, or whenever the contract ends, another $15 copay to reassess because we do have to reassess it. But that's much better, you know, and that can help with a lot of financial stress as well. So just to kind of keep that in mind to expand maybe what VA can help with your client with. And this is just the references that was used for the PowerPoint that we included. And this is my contact number. For the program, this is the program number. It is a cell phone. It's mine. It goes, you know, I'm the one that has access to the information or the surrogate that is in my place if I'm not there. And I do choose to use the cell phone because I do have voicemail that is confidential. My concern with some of the emails that go back and forth is that people might put HIPAA information in the subject line or they're not encrypting the email. So then we have HIPAA stuff exposed. Just my attempt to try to prevent that. And I think that's pretty much what I have. I would say if you have a question, you're working with a family, you know, there's stress going on, and you think there might be some assistance that maybe VA could provide, or we have a veteran, it's okay. Give me a call. I'm more than happy to staff that with you. I was a PAC social worker prior to that for 5 years, and that was my job, is to work on the home health aides and some of the other supports to go into a home or to give people relief to prevent things from being so stressful or escalating, and trying to preserve the health of both the caregiver partner as well as the veteran. And that's pretty much what I have. So,
Rhonda, thank you so much. It's a lot of really good information. I think I have a few questions, but of course, as anyone else has questions, feel free to jump in. Um, Kim Ranger mentioned in the chat the program you're talking about for the in-home health is amazing. So just to give you that feedback that we had that in there. What does you and I met yesterday to kind of just go through a basic thing, and you had been coming off a call and some stuff that was happening. Can you give us an idea of what your day to day looks like in your job? And, you know, the chaos, because every day is different, but I'd love to hear more about what it looks like for you and what that outreach from individuals looks like when they're reaching out to you or they're going through eligibility, that kind of stuff.
yeah. So a lot of times when people reach out to me, I mean, I've had veterans and partners reach out just to the cell phone number that I gave you. And so they can call me direct. They do not have to go through their provider to be able to get a hold of me. And some other programs, like even mental health, that is the route. Um, you know, I don't know. Sometimes I have people that call me for strength at home. And as we're talking and I'm doing the assessments, it's like, well, we have this RISE program. You know, are you sure on this? It seems like, you know, there's very little that you are doing with someone else, but it seems like there's a whole lot coming at you. And just kind of working with them on that and kind of strategizing with them. We also have within VISN 19, so we have a big collective of states. And within that states, each one has a coordinator. And what we've done with the Strength at Home program, the RISE program, and then we also have a program called Courage, which I'll go through real quick, we are taking referrals in on a VISN level. So as a result, the Strength at Home now has increased for men to where I can almost offer them a new group every month, which is unbelievable because before that, before January, it was pretty much when I had enough people, then that's when we would hold a group. So it could be 3 to 4 months. Um, but now we have that available almost monthly. The women's Montana is kind of trying to take that on a little bit and get that going. So it is when we have enough people to hold a group that we will start it. And we do have one coming up in August. Courage is about sexual assault through the lifetime. It is 12 weeks and it is a group format. The person really does need to be involved in mental health for that because it is kind of like a psychoeducational group type of intervention. And we want to make sure they have support. That can be done on a VISN referral. Montana directly does not have anyone for that, but we're able to offer that for veterans. All of our intervention currently is through VA Video Connect. Even this Strength at Home, because I need 2 facilitators to hold a group, I'm hoping that I have a couple clinics that we can try doing the in-person because we really want to do that. But right now, that is one of the things that, can be a barrier for some people that have hearing issues. But we do have Digital Divide. That is a program within VA. So we can have the PAC social worker talk to them and evaluate. And if they meet the criteria, we can do a loaned video device that is for nothing but VA programs. And they can do our group interventions from that. And then we also talk, the PAC social worker will talk to them about ways that they can end up getting their own device as well. So I have people coming in from many different things. Usually they're coming to me though about IPV. And as I'm doing my assessment, that PACT social worker kind of comes in on me and I start evaluating what else is going on in your environment. Is there anything else in VA that I can help make a referral or coordinate that would help you out further, like the home health aides? If we have a person that is taking care of grandpa, and maybe grandpa's moved into the home, that's also causing stress. How about we talk about maybe some ways that we can alleviate that? We even with our home health aides, we have provisions that if family members are providing the care already and they are doing the job, there is actually a program called Veteran Directed that allows the veteran to hire them as caregivers, which helps. If we're going to be paying somebody and they're doing the job, why not have it be the family member? The family member also has the choice to even go under an agency, and we have a few agencies that are willing to hire and train family members and not have them take on additional clients, just the one they have, which is their family. So there's a lot of creativity that we can look at and kind of dovetail in to see how we can help. And I do that type of assessment when I talk with either the partner or the veteran on it. I do look at the relationship health safety screens. I have a big deep dive in that. 80% of my time is supposed to be administrative. Right now, I'm pulling in a lot of clinical just because we have had staff changes and reductions in staff. So that's where I'm putting it right now. But the other piece is the administrative, where I look at the annual screens done, kind of pull out problematic areas, talk to staff, work on education. I will be gearing up for that real soon, how to do a relationship health safety assessment and safety planning, and what do you need, which can include community contacts. What do you need when you have that upfront situation with someone where you need to work on safety today? Because at being a solo person, I'm not able to hit everyone. So it's about how can I navigate, work with the team, as well as do individual and just kind of do that overall coordination.
I mean, that's a lot. There's a lot that goes in, and especially when you think about all the different hats you're having to wear as you navigate that. Do you think that your experience having worked in PACT benefits your ability to see the holistic and help someone on all aspects as you're navigating these systems?
Oh, yeah, definitely. Being a PAC social worker, I felt like I was the little boy sticking my finger in the dikes until someone could come along and give me some relief. Also, just my history in child protection services and adult protection services. I had 23 years, 23 and a half years in that area. And that's what that is all about within, again, a certain population, but it's about the networking and trying to create that support group and thinking ahead that when you are gone, some of that funding's gone. How are we going to continue, to give these people the support they need? So yeah, I think probably a combination of a lot of things that I've done in my life. I've never
Absolutely.
been one that could stay strictly in one lane, either being a therapist or a case coordinator. I kind of always wanted to do it all. So I kind of go back and forth.
I think that works really well for this particular position too, is that you are like
Mhm.
you're doing a lot of that coordination, but you get to add that caretaking and that like walking someone through the process, like that piece of it. So that's a really positive part of it. Um, One of the questions I had that is really that basic question that I've heard before. I did not, prior to having met Vance and having met you, I didn't have a solid understanding of what eligibility for veteran meant, that there's very
Right.
specific requirements. Can you give those to us just so people know what we mean when we're saying veteran that has access to the Veteran Health Administration and thus the IPV program?
So if someone is enrolled in Veterans Health Care, they will be attached to a team, and we call it a PAC team, but they will have a provider, whether that be a nurse practitioner or an MD, they'll have a nurse, an RN, an LPN, they'll have a scheduler. That is the primary PAC team that will do their care. And each team in Montana, they chose to name them by animals. So, like in Butte, we have the husky team, we have the cougar, and we have the otters. And so, you might hear people reference to that, or they'll just say, this is who I see, this is my provider. Um, but they will be definitely they'll be able to say they're attached to someone or that they're going to a location. So each clinic is an outpatient clinic, and we do have them in different parts of Montana. And then also there are PAC teams for outpatient up at Fort Harrison. So just because a person is in Butte doesn't mean they automatically go to the Butte clinic. They could go to Bozeman, Billings, they could go to Helena. They have freedom of choice as far as where they want to go. There are some programs, with transportation, and everything has its own qualification, but usually the transportation is based on where they're at to the nearest clinic, not necessarily the one they may attend. Um, I kind of forgot your question, I guess. Oh, the eligibility. Okay. So if a person is not, I mean, if there is some concerns about, are they eligible or not, I would just reach out, have them reach out to me. I guess I would say I would not be able to get that information out unless it's to the veteran or unless there's a release of information. But it could be that I could give a phone number and have some follow up calls go in that direction. If they are not eligible, then that first hyperlink that I gave you under enrollment. So on the resource page, it had enrollment. That is where I would go. I mean, that's what I do is I pull up the internet and I'm looking at it and going through it with the veteran and the family. Um,
So
No,
I wouldn't.
yeah, VHA resources under enrollment. So the first and second one will be the websites that you could look at that give you the general information. And the third one was the application form itself. And that does need to be filled out. They are going to ask income information. Um, and they are going to want a copy of that discharge paper, which is a DD 214, and it's also been by other names too. It just depends on the era that they discharged from.
And I think you started to talk about it. One of the things that I hadn't known ahead of time was that in my head, and this is just really, it was a learning curve for me, was I had just assumed that everyone who had participated in the military, whether they'd done that, would qualify for veteran services. And that's not the case, actually. It has to, right? Like um, they have to have had some sort of deployment, right? There's some rules around what that part means. Can you give us a quick snippet on what that part looks like?
Well, I think you're kind of pulling it up here. So this is
Okay.
for VHA. And the other thing too is VHA is about healthcare. And then we have another VA, which is benefits with the veteran service officers. And that's a completely different thing altogether. So if we're looking at a service connection, it's actually going to be in that direction. It's not going to be with the clinic because the clinic's about providing medical care or clinical care. And so there is a whole different administration that focuses on benefits. And sometimes some of that paperwork will come over, where a person might need to make an appointment with their provider just to go through the paperwork that the veteran service officer needs to see if there's a service connection. But it's very much guided by the veteran service officer of what is in place. And it's not something that typically is done in an existing appointment because it has its own time dedication. It's pretty thorough. And so the provider has to shift gears and really kind of go through the chart and diagnoses and labs and the whole bit as they're answering some of these questions.
No, that's great. Thank you for that. And I just wanted to share it so people could see the enrollment, eligibility, that kind of stuff is
Mm-hmm.
right there on that one. All clickable links. That's been put in the chat. I'll also post it when when I edit the video. Like I said, I'm weirdly a little behind. I have two that have been updated, which was the state needs assessment and then the Yellowstone human trafficking, but I had somehow missed the Saki unit one. So I've got some videos and then I'll get this one posted and added, but give everyone that opportunity. You talked a lot about the work you do and the things you hear and stuff and how busy it is and what the different hats look like. How do you take care of yourself? At the end of your day, how do you take care of yourself after hearing the things and working through these processes with people?
Well, I think it's not just the end of the day. I mean, even when I was in PAC social work, I also went through a program, and this is within VA on clinical hypnosis and self-clinical hypnosis. And it's just kind of, you practice what you preach as far as in groups and the interventions you do about how to get back to being very self-aware of you and what is going on. So one of the components, the anger analysis form that is completed every week in Strength at Home, is to focus on that awareness. So it's about what is your body physically doing, or is there any part of you that's tight, your muscles, etc. What is your emotions? What are you feeling? And then what are you thinking? And we try to get people back to being very aware about what is going on in their body and that their body is actually giving them information up front to say, hey, you're stressed. You need to do something. And if we ignore it, then that's where we start having a lot of that, what I would say is a fight or flight brain, where, everything is a crisis, even though it shouldn't be. We just want to get through it. Our muscles are tight the whole bit. And if we live in that environment, very clearly there is strong connections, especially with women on, fight or flight, stress, and heart disease, heart attacks. Because you think about it, all that blood is going into, go out. It's in your limbs and things like that, but it's to be used for something. And if we never do it, we can become toxic, to ourselves. So sometimes even before I get the next patient, if I finished with one, it's just taking literally less than 3 minutes, if whether it's just even the breathing, taking a deep breath in, counting for four, exhale for four, count for four, up again, doing the square. Or I just got through with one on a program where they talked about just even yawning. If you yawned every single hour, and yawning doesn't take too much to do. I mean, if you think about it, your body starts to yawn, but it's that deep inhale in and that exhale out that your body just does relax. Your shoulders just go down just in doing that and taking that pause and that inventory, those three things. And where am I at? Because I want to go out giving the face of openness, happiness, happy you're here, looking forward to you, not someone that's stressed and kind of a crank, going out and visiting with, a new patient. That's not what they waited for.
I thank you for sharing that too, because I think first off, I am so susceptible to yawning. The second you said it, I was like, it's gonna happen to me
I
now. I
saw
know
you
who
do
I
it.
am. I know. I was like, I can't even hide this. I like the second I
Yeah.
think someone else is gonna yawn, I'm the one yawning. This information isn't only great, like to think about what you've done to navigate this, but I also want to put in perspective that part where you spent 23 years in adult and child protective services, and those jobs are draining and they take a lot
Mm-hmm.
away. And like to still have that thought process, I think is just so honorable. And like it's so amazing to hear you talk about it in that way because you're right. Like we don't want to go meet the people we're meeting with or the people we're serving and helping as a cranky, crabby person. And of course, we all have bad days, right? Like, and I'll admit my bad days. I'm quick to be like, nope, Tawny doesn't have the capability today. But it's great to hear you talk about that with knowing what your extensive experience is like. So as we close out today, what's one thing you hope people can take away from today?
Well, what I'm hoping for is just keeping it in your mind that if there might be a veteran in the family that you're working with, and it might be if that person is eligible for VA services, that there could be some additional support so that the people in the home are not carrying the load. Um, they're even just being a partner to reach out, to talk to myself. It might be that they're heavily connected with people in the community, but I can still talk to them about what the programs are, what's out there. Some of the partners, they'll say, well, I think they can hear that, but I need to time it. But it's good to know what's there. And I do offer, I say, I am always available. You could give that person my phone number. I could do just even a joint call if, that person felt more comfortable having someone there with them just to talk about the program and helping them see if this would be a fit for them. And then if it is, then, I can schedule. I also want you to know that I'm out there. So if you have a family that has a military or veteran in their home, it doesn't hurt. You please reach out to me. I can talk to you about the specific, you can give me the specific needs of the family and I can say, well, here's what VA might be able to provide. At least you can take that back. I do worry that sometimes we give a phone number and then we have multiple people bombard them. And sometimes it's just nice to have that center person that does that introduction. And it doesn't have to be me. You can talk to them about, well, I think there's this program. Here's this woman that might know more. Are you interested in giving the phone number to them? Very happy to do that if the person is even court involved. I mean, the nice thing about Strength at Home, which, there is some contradiction with that, but the fact is with Strength at Home, it's going to be that upfront cost for us to do the evaluation, which is $15. And
Oh,
it doesn't matter how long they stay with me, it's $15. So it's based on them coming in and how many times they're seeing someone, not the length. Um, but also, I think I was going to kind of go somewhere with this. I was mentioning that this Strength at Home. That other than that, because it is a group format with VA, there isn't a charge after that. So some of these other programs, they're going to charge by session or they're going to charge by hour in the community. If it is a veteran, it's going to be that one upfront cost, and then after that the group involvement, it's not going to cost them, which means we might have somebody that can put that money in somewhere else that is necessary on maintaining the home or child support or whatever else that is needed. So that can be an assistance as well.
Absolutely. Well, perfect. Thank you so much, Rhonda, for doing this today. This is a lot of great information. It helps for our group to know as well that you exist. Does anyone have any additional questions before we close out for the day?
Rhonda, I was just wondering, I have people that live in Kalispell, and I was just wondering if do you have need for volunteers?
You know, with the strength that there is a program that was out there for volunteers, and it was coming through Fort Harrison. And I'm not sure if that program is still running. But what I can do is I can look into that. And if it is, I can give you the contact information and you can reach
Mm,
out to them because they
okay.
had a program going on where it was kind of a greeter situation, just even being in clinic, with people waiting. Um,
Mm-hmm.
and being able to support them, or they might be filling out an application, and sometimes it's not that you fill it out, but it just helps to have two heads. People feel a little more comfortable because they get nervous about filling government forms out. Am I doing it right? And it's like, well, from what I can see, yeah, we'll ask this person here, just someone that is there for them. So I don't know if that is something that you're interested in, Susie. And if so, if you have a contact number, I can look into that for you.
Well, my sister-in-law had just in the last several months, her husband went into the veterans home,
Mm-hmm.
and it's just been such an asset. And she's the type of person that would be a good fit to volunteer, like something like that, just to be supportive.
Mm-hmm.
I mean, I don't know if she's interested, but I
Well,
she's trying to figure out where she fits now in the world
yeah, yeah, I
after
get
she's been
that.
a caretaker for so long, and then um,
Well, feel free to give my contact information out to her and I can talk to
okay,
her on that. And I don't know, what I would have, but I would certainly look into it. Um,
So
because
that
there's
was
also a couple of community programs that serve veterans too. And I
a
could at
really
least,
good. Oh, sorry, Rhonda.
yeah, no, that's okay. I could at least give them some contact information and, she could follow up.
yeah,
So
Yeah.
that was also a
No.
good point for me to consider too, because I put together the resource sheet based on what Rhonda and I talked about. But what I'm going to put at the bottom is Rhonda's information with her phone number. So that way, when people go to look at the resource sheet, your phone number is right there for them to reach out and do that kind of stuff. So we'll make that a little bit
Hmm.
easier.
Okay. Sounds great.
Perfect. All right. Well, I appreciate you all. Rhonda, this was amazing. Thank you for sharing this. I will make sure that these resources are available to those that need them as far as reaching out and getting that information. One of the things that Rhonda and I have talked about, one of the things that you can see if you visit the Strength at Home website is that while this was created initially for veterans, we are starting to see them wanting to reach out more into communities.
Hmm.
So I'm excited to see what that looks like. I've been fortunate to do some of the regional IPV conferences when they were virtual in I think it was 2022 and 2023 I did them, but they were such a great opportunity to learn more about the Strength at Home program too and what it looks like. It gives us that additional context as we look at IPV and what it means when we have complex trauma and complex situations that are being added onto it. So I appreciate you all. I'm going to end it for today. Rhonda, thank you. If anyone has questions or needs additional contact information, please don't hesitate to reach out to me. I will get that information sent over to you. And Susie, I will send you that stuff by the end of the day today, so you have Rhonda's contact information and you can share it.
Okay, thank you.
Awesome. Have a great rest of your week, everyone. I'll see you in 2 weeks.